Chapter 48, Part 1 Liver, Biliary Tract, and Pancreas Problems. Let's start with hepatitis. Hepatitis is an inflammation of the liver that has various causes, viral being the most common, but can also be due to alcohol, medications, chemicals, autoimmune diseases, and metabolic problems. Hepatitis has many different types, the first being hepatitis A, which is a virus, ranging from mild to acute liver failure. It is not a chronic disease, and the incidence has decreased with vaccination. It is transmitted by the fecal-oral route and is usually due to contaminated food or drinking water. When you hear about people contracting hepatitis from the fast food drive-thru, it's usually hepatitis A. Hepatitis B, on the other hand, is another virus that can be either acute or chronic. The incidence is also decreased with vaccination, and the virus is transmitted perinatally, percutaneously, or via small cuts on mucosal surfaces and exposure to infectious blood or blood products. This is going to be one of those blood and sexually transmitted hepatitis. People at the most risk for hepatitis B are men who have sex with men, household contact of chronically infected, patients on hemodialysis, healthcare and public safety workers, IV drug users, and recipients of blood products. The hepatitis C virus can go from the acute stage, which is asymptomatic, and its chronic stage, causing extensive liver damage. And again, this is a virus transmitted percutaneously, with those at highest risk including IV drug use, high-risk sexual behaviors, occupational exposure, perinatal exposure, and blood transfusions before 1992. And then there's hepatitis D, also called Delta virus. And this is a defective single-stranded RNA virus that cannot survive on its own. It requires the hepatitis B virus to replicate, and is again transmitted percutaneously and with no vaccine available. The hepatitis E virus is an RNA virus, transmitted again via the fecal-oral route. It's the most common mode of transmission, includes drinking contaminated water. It occurs primarily in developing countries, with few cases in the United States. Under the acute infection of hepatitis, a large number of hepatocytes are destroyed. The liver cells can regenerate in normal form after resolution of the infection. Under chronic infection, this can cause fibrosis and scarring that progresses to cirrhosis. During the infection, antigen-antibody complexes activate the complement system. This results in systemic manifestations including rash, angioedema, arthritis, fever, malaise, glomerular nephritis, and vasculitis. As we said, the clinical manifestations can be classified as either acute or chronic, with many patients being asymptomatic. The symptoms could also be intermittent or ongoing, such as anorexia, malaise, fatigue, lethargy, myalgias, and right upper quadrant tenderness. Under the acute phase, the maximal infectivity lasts 1 to 6 months, with symptoms during intubation including nausea, vomiting, that right upper quadrant tenderness, a reduced sense of smell, finding food repugnant, and a distaste for cigarettes. The physical findings within the acute phase could also include hepatomegaly, lymphadenopathy, or splenomegaly. Jaundice may also be present, and if so, the patient may have symptoms like dark urine, light or clay-colored stools, and pruritus. During the convalescent phase, it will begin as the jaundice is disappearing, and could last weeks to months. Other major problems would include malaise and easy fatigability. The hepatomegaly persists while the splenomegaly begins to subside. And finally, during recovery, most patients recover completely with no complications. Most cases of acute hepatitis A especially resolve, though some hepatitis B and most hepatitis C result in chronic hepatitis. Other major complications include acute liver failure, that chronic hepatitis of some hepatitis B and C infections, cirrhosis of the liver, portal hypertension, and liver cancer. Under acute liver failure, the manifestations may include encephalopathy, GI bleeding, disseminated intravascular coagulation, fever with leukocytosis, and a liver transplant usually being the cure. For chronic hepatitis, hepatitis B is more likely to develop in infants and those under the age of 5. Hepatitis C virus infection is more likely than hepatitis B to become chronic, with less than 50% of immunocompromised adults that are acutely infected with HBV progressing to the chronic infection. The risk factors for developing cirrhosis include male gender, alcohol use, fatty liver disease, and excess iron deposition in the liver. For patients with hepatic encephalopathy, this is a potentially life-threatening spectrum of neurobiologic, psychiatric, and motor disturbances. This results from the liver's inability to remove toxins, especially pneumonia. Ascites could also be present. This is an accumulation of excess fluid within the peritoneal cavity. Our diagnostic studies would include specific antigen or antibodies for each type of viral hepatitis. It would also include liver function tests, viral genotype testing, a physical assessment of the patient's findings, and a liver biopsy. Laboratory results may show disturbances in hemoglobin, bilirubin, the alkaline phosphate, ALT, and AST. In addition, be sure to test the urine for bilirubin. There would also be specific labs for each antigen and antibody related to the different types of viral hepatitis. Under the care of a patient with both acute and chronic hepatitis, they should receive a well-balanced diet in addition to vitamin supplements. They should also receive adequate amounts of rest, avoid alcohol intake and any other drugs detoxified by the liver, and a notification of possible sexual contacts. Under drug therapy, it would depend on the different types of hepatitis, such as with hepatitis A having no specific drugs, and hepatitis B only if the infection is severe. Some supportive therapy would include antihistamines and antiemetics. When treating chronic hepatitis B, the drug therapy would focus on decreasing the viral load, the patient's liver enzyme levels, and the rate of disease progression. We also want to work to prevent cirrhosis, portal hypertension, liver failure, and cancer. The use of interferon, which is a naturally occurring immune protein. It is an antiviral, antiproliferative, and immune modulating effects. It also has side effects, including flu-like symptoms and depression. While there is no special diet needed, emphasis on a well-balanced diet that the patient can tolerate. There should also be adequate calories that are important during the acute phase, as well as fat content may need to be reduced. Vitamin B complexes and vitamin K, in addition to IV glucose and enteral nutrition. Our subjective data would include things like hemophilia, exposure to infected persons, ingestion of contaminated food or water, the ingestion of toxins, past blood transfusions before 1992, and other risk factors. We should also be assessing for medications such as Tylenol and over-the-counter meds and herbal medications that are also processed by the liver. For our subjective data, it should also include functional health patterns such as IV drug and alcohol abuse, a distaste for cigarettes, high-risk sexual behaviors, weight loss, anorexia, nausea, vomiting, right upper quadrant abdominal discomfort, urine and stool color, fatigue, arthralgias, and myalgia, and exposure to high-risk groups. Our objective assessment would focus on low-grade fever, jaundice, rash, hepatomegaly, splenomegaly, and abnormal laboratory values. When planning their care, the patient will have relief of discomfort, be able to resume normal activities, and return to normal liver function without complications. For the health promotion within hepatitis A would include personal and environmental hygiene, as well as active immunization. This would include children at 1 year of age and adults at risk. Post-exposure prophylaxis of hepatitis A vaccine and immune globulins, as well as special precautions. The health promotion for hepatitis B would also include immunization, with vaccines such as Energex, and this would include a series of 3 IM injections, which should be received by all children and at-risk adults. For hepatitis C, there is no vaccine available. Treatment would include general measures to prevent the hepatitis C transmission, screening all persons born between 1945 and 1965, and no post-exposure prophylaxis, including baseline and follow-up testing. During acute care, we should assess for jaundice, comfort measures, as well as adequate nutrition, including small frequent meals, measures to stimulate the appetite, carbonated beverages, and adequate fluid intake. It should also include physical rest, modified activity plan, physiologic and emotional rest, and diversion activities. During ambulatory care would include dietary teaching, planning activities after periods of rest, teaching how to prevent transmission, symptoms to report, and the assessment for complications. Ambulatory care would include regular follow-ups for at least 1 year after diagnosis, abstaining from alcohol, and medication education, including how to administer the interferon, as well as the side effects, also advising them that no blood donations should be occurring. Our expected outcomes are that they maintain food and fluid intake adequate to meet their nutritional needs, avoid alcohol and other hepatotoxic agents, show gradual increase in activity tolerance, and perform daily activities while scheduled rest periods. Next, let's talk about cirrhosis. Cirrhosis occurs in end stage of liver disease and is from extensive degeneration and destruction of liver cells. It results in the replacement of the liver's tissue by fibrous and regenerative nodules, and usually happens after decades of chronic liver disease. Most common causes in the United States are chronic hepatitis C and alcohol-induced liver disease. Other causes include extreme dieting, malabsorption, obesity, environmental factors, and a genetic predisposition. Other forms would include biliary cirrhosis or cardiac cirrhosis that results from long-standing severe right-sided heart failure. There are a few symptoms in the early stage of the disease, and fatigue and enlarged liver may be an early symptom. Blood tests may even come back normal, called compensated cirrhosis. Late manifestations resulting from liver failure and portal hypertension include jaundice, peripheral edema, and ascites. It could also include skin lesions, hematologic problems, endocrine problems, and peripheral neuropathies. The jaundice, or yellowing of the skin, results from the decreased ability to conjugate and excrete bilirubin. This results in an overgrowth of the connective tissue in the liver as it compresses bile ducts. This leads to obstruction and increase in the bilirubin within the vascular system. These skin lesions are due to an increase in the circulating estrogen due to an inability of the liver to metabolize steroid hormones. This results in spiderangiomas and even erythema. Other hematologic disorders include thrombocytopenia, leukopenia, anemia, and other coagulation disorders. Endocrine problems may also occur, secondary to decreased metabolism of hormones. In men, gynecomastia, a loss of axillary and pubic hair, testicular atrophy, impotence, and a loss of libido. In women, amenorrhea or vaginal bleeding may occur. Peripheral neuropathy is a common finding in alcoholic cirrhosis and is a result of dietary deficiencies of thiamine, folic acid, and cobalamin. Compensated cirrhosis and decompensated cirrhosis that includes portal hypertension, esophageal and gastric varices, peripheral edema, abdominal ascites, hepatic encephalopathy, and hepatorenal syndrome. Portal hypertension results from the increased venous pressure within the portal circulation. It also goes along with splenomegaly, large collateral veins, ascites, and gastric and esophageal varices. Esophageal varices are a complex of tortuous and large veins at the lower end of the esophagus. Gastric varices, on the other hand, occur in the upper part of the stomach. Both are very fragile and bleed easily, with most being life-threatening complication. Peripheral edema occurs due to the decreased colloidal oncotic pressure from impaired liver synthesis of albumin. It also results from the increased pressure from portal hypertension. Ascites is specifically the accumulation of serous fluid in the peritoneal or abdominal cavity. It has several mechanisms, including portal hypertension, hypoalbuminemia, and hyperaldosteronism. Hepatic encephalopathy can cause severe confusion in the patient, and it results from the neurotoxic effects of ammonia, also causing abnormal neurotransmission and inflammatory cytokines. The liver is unable to convert increased ammonia to urea and excrete it from the body. Hepatic encephalopathy results in changes in both neurologic and mental responsiveness, impaired consciousness, inappropriate behavior, as well as sleep disturbances, trouble concentrating, and even coma. Other common symptoms of hepatic encephalopathy include asterixis, which is a flapping tremor most common in the arms and hands, impairment in writing due to the difficulty in moving the pen left to right, and fetor hepaticus, a musty, sweet odor on the patient. In hepatorenal syndrome, renal failure with azotemia, oliguria, and intractable ascites occurs. There are no structural abnormalities of the kidneys. The portal hypertension leads to vasodilation, which leads to renal vasoconstriction. Treat with liver transplantation. Our diagnostic studies would include liver enzyme tests, total protein and albumin levels, cholesterol levels, prothrombin time, ultrasounds, and liver biopsies. Our care would include rest, the administration of B-complex vitamins, the avoidance of alcohol, and the minimization or avoidance of aspirin, acetaminophen, and NSAIDs. The treatment for ascites would include sodium restriction, diuretics, and albumin. Ascites may also be treated with paracentesis or a transjugular intrahepatic portosystemic shunt, a TIPS procedure, among other shunts. Esophageal and gastric varices help to prevent bleeding and hemorrhage. The patient should avoid alcohol, aspirin, and NSAIDs. Also, screen for the presence with an endoscopy. If bleeding does occur, stabilize the patient, manage the airway, start IV therapy and other blood products. This emergent procedure will also include a balloon tamponade, in which case a mechanical compression of the varices is occurred. Other supportive measures for that acute bleed include fresh frozen plasma, packed red blood cells, vitamin K, proton pump inhibitors, lactulose, and antibiotics. The long-term management would include beta blockers, repeated band ligation, and portosystemic shunts. Shunting procedures are done more after the second major bleeding episode, and non-surgical care would again be that TIPS procedure. Hepatic encephalopathy would also be treated with drugs like lactulose, which trap the ammonia within the gut. Also, treatment of the precipitating cause by lowering dietary protein intake, controlling GI bleeding, and removing blood from the GI tract. While there is no specific drug therapy for cirrhosis, several drugs are used to treat the symptoms and complications of advanced liver disease. There should also be a diet for patients without complications that includes high in calories, high carbohydrates, and moderate to low fat. The nutritional therapy would include protein supplements for protein-calorie malnutrition, low-sodium diet for patients with ascites and edema, seasonings to make their food more palatable, and collaborating with a dietitian. Our subjective data would include a past health history, including a history of hepatitis, NASH or non-alcoholic steatohepatitis, chronic biliary obstruction and infection, and severe right-sided heart failure. Other subjective data would include chronic alcohol use, weakness, fatigue, anorexia, weight loss, nausea and vomiting, or gingival bleeding. We should also be assessing the patient for dark urine, decreased output, light-colored or black stools, flatulence, change in bowel habits, dry yellow skin, or abnormal bruising. Also included in the assessment would include right upper quadrant pain or epigastric pain, numbness, tingling, pruritus, impotence, or amenorrhea. Our objective data would include fever, cachexia, wasting of extremities, icteric sclera, jaundice, petechia, ecchymoses, spider angiomas, alopecia, or peripheral edema. Other objective data would include shallow rapid respirations, epistaxis, abdominal distension and ascites, distended abdominal wall veins, palpable liver and spleen, foul breath, hematemesis, and hemorrhoids. The patient should also be assessed for altered mentation, asterixis, gynecomastia, testicular atrophy, impotence, loss of libido, and amenorrhea. Other assessments would include anemia, thrombocytopenia, leukopenia, decreased serum albumin and potassium levels, abnormal liver function studies, increased INR, increased ammonia and bilirubin levels, and abnormal findings on the abdominal ultrasound. The nursing management would include impaired nutritional status, ineffective tissue perfusion, activity intolerance, and fluid imbalance. Our overall goals would be the relief of discomfort, minimal to no complications, and a return to as normal a lifestyle as possible. Health promotion should include the reducing or eliminating risk factors, treating their alcoholism, maintaining adequate nutrition, identifying and treating acute hepatitis, and bariatric surgery for the morbidly obese. The acute care would include those rest requirements previously discussed, as well as nutritional needs, including oral hygiene, between meal snacks, offering their preferred foods, and an explanation of their dietary restrictions. Measures to relieve pruritus may include hydroxyzine, baking soda or alpha carry baths, lotions, soft or old linen, antihistamines, temperature control, and making sure that their nails are shorter. We should also be closely monitoring the color of urine and stools, obtaining accurate I's and O's, daily weights, assessing their extremity movement, as well as frequent abdominal girth measurement. When performing a paracentesis, the patient should void immediately before. It would be completed in the high Fowler's position or sitting on the side of the bed. Closely monitor the patient for hypovolemia and electrolyte imbalances. Monitor the blood pressure and heart rate closely. Also, monitor the dressing for any bleeding or leakage. When treating dyspnea, have the patient positioned in semi or high Fowler's position. Also, the skin care should be accomplished with a special mattress and closely adhering to their turning schedule at least every 2 hours. This would be in addition to range of motion exercises, coughing and deep breathing exercises, and elevating the lower extremities. Monitor for fluid and electrolyte imbalances, including hypokalemia and water excess. Observe for any bleeding tendencies and assess the patient's response to any altered body image. When dealing with bleeding varices, closely observe for any sign of bleeding. For that balloon tamponade care, make sure that you're carefully explaining the procedure, checking for patency, and confirming the position of the balloon. We should also be monitoring for complications such as aspiration pneumonia, keeping scissors at the bedside in case of emergency, making sure the patient stays in a semi-Fowler's position, and closely monitoring oral and nasal care. For hepatic encephalopathy, maintain a safe environment and carefully assess their level of responsiveness, sensory and motor abnormalities, fluid and electrolyte imbalances, acid-base imbalances, and their response to treatment. Assess their neurologic status every 2 hours, also working to prevent falls and injuries, minimizing constipation, encouraging fluids, and controlling factors known to precipitate encephalopathy. And it can't be stressed enough the importance of supportive measures such as proper diet, rest, and avoiding potentially hepatotoxic over-the-counter drugs. The ambulatory care would include community support programs, symptoms of complications, when to seek medical attention, written instructions with adequate explanations for a patient and family, and a referral to community or home health nursing. And finally, when evaluating these patients, it should include a maintenance of food and fluid intake to meet their nutritional needs, maintenance of their skin integrity, normalization of fluid and electrolyte balance, and a treatment for substance abuse. But anyway, that's all we've got for this chapter. I'll see you in part 2.